So I'm going to be speaking today about the diagnosis and management of acute and chronic pulmonary embolism. We're going to talk about the current state of the field and where things are going. So a brief outline of the talk. We're going to talk a little bit, very briefly, about the pathophysiology of acute pulmonary embolism, as well as the epidemiology, the presentation and current risk stratification tools that we have for patients with PE, optimal therapy for pulmonary embolism based on risk stratification, the current evidence for some of the advanced therapies that we have in intermediate and high risk pulmonary embolism, some ongoing trials, as well as late-term complications of pulmonary embolism, including chronic thromboembolic disease and pulmonary hypertension. We'll also talk very briefly about the surgical versus catheter-based therapies for chronic thromboembolic pulmonary hypertension, and then some conclusions. So acute pulmonary embolism is a thromboembolic event, so a VTE. It most commonly arises from a pre-existing deep vein thrombosis of the lower extremities. The lower extremities are much more likely to cause a PE than any upper extremity DVT due to differences in anatomy. When we think about venous thromboembolic disease, we think about Virchow's triad that we all learned in medical school, which includes some sort of endothelial damage, a hypercoagulable state, and some level of venous stasis. So endothelial dysfunction can arise from either lifestyle factors, including smoking and hypertension, or surgery, some catheters, or recent trauma, particularly in lower extremities. Hypercoagulability can be due to a host of reasons, both hereditary and acquired. On the hereditary side, we have things like factor V Leiden, prothrombin gene mutations, protein C and S deficiencies. On the acquired side, we think about cancer, chemotherapy, hormone replacement therapy or OCPs, pregnancy in particular, obesity, and certain acquired thrombophilias. Stasis, really, we think about immobility, surgery, polycythemia, other things like that that may cause a decrease in our venous blood flow. So PE is important. It's got an increasing incidence over time, despite us knowing about this for an extended period of time and working to improve these outcomes. However, we see that it's the third most common cardiovascular disease after myocardial infarction and stroke. And up to 4 to 10% of patients who suffer a pulmonary embolism will go on to develop pulmonary hypertension at 2 to 3 years. 15 to 20% will not return to their normal baseline function. We see on this graph here over time, we have VTE, DVT, and PE are all increasing over the years. This is in part due to an aging population and our ability to treat certain conditions that otherwise may have led to mortality in the past, but predispose patients to venous thromboembolic events. So what's the danger in PE? This graphic here is what we call the RV spiral of death. And so when we have a pulmonary embolism, many people think that this is a problem with the pulmonary system, but it's really a cardiovascular problem. And so when the right ventricle sees an acute increase in RV afterload, this leads to RV dilation, tricuspid valve insufficiency, increase in the RV wall tension, which leads to neurohormonal activation, myocardial inflammation. These in turn increase the oxygen demand of the right ventricle. There's additionally intrapulmonary arteriovenous shunting due to blockage of some of the blood supply through the pulmonary system, which leads to RV ischemia and hypoxic injury. This in turn leads to decreased RV contractility, decreased RV output, which then leads to decreased LV preload, a decrease in cardiac output, decrease in systemic blood pressure and coronary perfusion, and therefore decrease in RV oxygen delivery. And this spiral goes down, and if left unchecked, leads to obstructive shock and ultimately death. So mortality rates in pulmonary embolism are high. This is why we care about it so much. In an unselected population of patients with pulmonary embolism, 11.4% of patients were dead at 2 weeks and up to 17.4% at 3 months. When we look by risk strata and we look in the massive or high-risk pulmonary embolism population, taking all comers, mortality rates range from 18 to 65%. In patients who are treated appropriately, this number drops down to about 20%. Those who present with shock have mortality as high as 30%, and those small population who present with cardiac arrest and are successfully resuscitated still have a 65% mortality rate. In the submassive or intermediate risk pulmonary embolism category, mortality rates are a little bit more modest, but still can be quite high, ranging from 5 to 25%. In patients who have a pulmonary embolism and are found to have what we term a clot in transit or a mobile thrombus in the right heart chambers, mortality can be as high as 27%. And then in the low risk patient population with small pulmonary emboli, even still, mortality rates are 1%. So, what are the risk factors that we think about when we're looking at a patient and wondering whether they may have a pulmonary embolism? Certain demographic factors, including age, particularly in those greater than 80, sex, women are found to have a higher incidence of pulmonary embolism than men, and BMI, with obese patients having higher rates of pulmonary embolism compared to the rest of the population. Lifestyle factors, including smoking and immobility, can contribute, and comorbidity, including heart failure, inflammatory conditions, particularly inflammatory bowel disease, prior stroke, prior VTE in the patient or even in their family, malignancy, recent surgery, trauma, particularly of the lower extremities, pregnancy, and hormonal therapy use can contribute. And as we said earlier, certain genetic thrombophilias may contribute to increased risk as well. So, what do the patients look like when they present to you? So, the symptoms that they may demonstrate are lower extremity pain, swelling, shortness of breath, cough, hemoptysis or coughing up blood, syncope, and chest pain. Signs that we're looking for include tachycardia, hypoxemia, hypotension, altered mental status, shock, cardiac arrest. These last two are quite rare, thankfully, but they still may be the initial presentation of a patient with a pulmonary embolism. When we look at laboratory evaluation of these patients, we look for things like elevated troponins or B-type natriuretic peptide, D-dimer, or serum lactate. On imaging, in addition to looking for thrombus in the pulmonary vasculature, we look for RV dilation and dysfunction, which we may see on a CT pulmonary embolism protocol or on any form of echocardiography. Additionally, we may see mismatched defects on a ventilation perfusion scan. This is a busy slide, and you don't need to memorize all of it. These are readily available and up to date. But these are some of the risk stratification scores that we use to determine the pretest probability of a patient having a pulmonary embolism. The most commonly used ones are the Wells scores and the modified Geneva scores. And we see on the left in the Wells score, we have things like clinical symptoms of DVT, if PE is more likely diagnosis than others, what their heart rate is, if they're tachycardic, have they been immobilized or had surgery in the last 4 weeks? They had a prior VTE. Do they present with hemoptysis, malignancy? And we score based on these scores to determine what the pretest probability is, low, mediate, or moderate, or high. And so how do we use these scores to then determine who we need to do further diagnostic workup in? This is again a busy slide, and it's an algorithm taken from up to date, but I think it's a very helpful one to help you think about how you might approach a patient in the emergency department who's presenting with signs and symptoms potentially concerning for pulmonary embolism. After you've done your Wells or Geneva score, in this case, we've used the Wells score. If a patient's low probability and they have a Wells score less than 2, we then try to apply what's called the PERT criteria, which is the PE rule out criteria, which we see on the left in this box. I'm going to put on laser pointer for you for a second. So if a patient is less than 50, not tachycardic, not hypoxic, no hemoptysis, no hormonal therapy use, no prior VTE, no leg swelling, and no surgery or trauma in the last 4 weeks, and is low risk, their Wells score is less than 2, we say that this person is ruled out for pulmonary embolism and they can be safely discharged. If, however, the patient is intermediate risk, Wells score of 2 to 6, we move to this level of this algorithm where we measure a highly sensitive D-dimer level. The D-dimer is a great test for the intermediate risk patient population because it has very high sensitivity, meaning its negative predictive value is quite high. Its sensitivity is quite low and can be positive in many other conditions. That being said, the negative predictive value is really what you care about when you want to rule out a pulmonary embolism and not potentially expose someone to undue radiation. And so if a patient has a negative D-dimer less than 500 nanograms per ml, you can say that that patient does not have a pulmonary embolism and discharge the patient. If, however, their D-dimer is elevated, we move to this next level, which is where you would start in this algorithm for any patient who is high risk or a Wells score greater than 6, which is a CT pulmonary angiogram if feasible. If it is, you perform this. If there's PE, you've diagnosed this. If there's not, PE is excluded. If, however, you cannot do this for some reason, particularly in patients who are not entirely stable or have significant renal dysfunction and the risk of giving them a contrast load would be prohibitive, you can proceed with ventilation perfusion scanning and then base your diagnosis on the likelihood of pulmonary embolism from that perspective. So, how do we diagnose PE? The gold standard is a CT pulmonary angiogram, which uses contrast, and this is the most common test that we use to diagnose pulmonary embolism. As we said above, a ventilation perfusion scan has decreased sensitivity and specificity compared with CTPA, but is a good modality in high-risk patients who otherwise cannot tolerate a contrast load. And then finally, echocardiography is the least common way of diagnosing PE, but sometimes is the first way that PE is identified, either through thrombus identified in the proximal TAs or within the right-sided chambers themselves. So when we're looking at a CTPE, what are we interested in knowing? We, of course, first want to know whether or not the patient has a pulmonary embolism. So is there a filling defect within the pulmonary vasculature? But one of the ways that we can further risk stratify patients is by looking at evidence of RV dilation dysfunction. And so in this case, the most commonly used metric is what's called the RV to LV ratio. And on a four-chamber view at the level just below the atrioventricular valves, we measure the diameter of both the RV and LV. And an RV-LV ratio greater than 9 was independently associated with a higher mortality rate compared to an RV-LV ratio less than or equal to 0.9. When we're looking at an echo, we have several ways of assessing the right heart. We can look on the peristernal long, on the apical 4, on the peristernal short axis, and then looking at the IVC, we may see dilation and dysfunction on any of these views. In the apical 4-chamber view, in addition to dilation, sometimes we may see, hypokinesis of the right ventricle with sparing of the apical segment. This is known as the McConnell sign. This is fairly sensitive and specific for pulmonary embolism, but can be seen in other conditions as well. On the peristernal short, we look for dilation, and in addition to that, we look for flattening of the interventricular septum, either during systole, diastole, or both, which speaks to the volume status and pressure status of the right ventricle. Oftentimes, patients who have an acute pulmonary embolism are going to have a plethoric IVC due to the increased pressure in the right-sided chambers. We also may see a mobile thrombus either in the right atrium, right ventricle, or very commonly crossing between the right atrium and the ventricle, known as a clot in transit. And as we mentioned earlier, this is the harbinger of poor outcomes, with up to 27% of patients having mortality at 1 month. We can also look at the tricuspid annular plane systolic excursion, where we take an M mode right through the lateral aspect of the tricuspid annulus and measure how far this moves during systole. Patients who have a TAPSE less than 1.2 are at increased risk of having some sort of process that's causing increased strain on the right heart. So how do we then risk stratify this patient? We've diagnosed a pulmonary embolism, and we want to know what the best treatment modality is. So in previous iterations of societal guidelines, in the US guidelines, PE risk stratification was according to massive, submassive, and low risk. However, this was not quite as granular in terms of what we wanted to understand. Sorry, my children are knocking at the door. This is not quite as granular as what we want to understand in terms of patient outcomes. And so the ESC, or the European Society of Cardiology 2019 guidelines on the diagnosis and management of pulmonary embolism, gave us this graphic for a more granular assessment of patients' risk with PE diagnosis. They are risk stratified into high risk, which are patients who present with pulmonary embolism and are in shock. And then we have the intermediate risk patients, which are further subdivided into intermediate high and intermediate low, and low risk patients. And this is based on several factors. One is the hemodynamics. And so everything below a high risk pulmonary embolism presentation is going to be a hemodynamically stable patient. Then we look at some of the PE severity risk calculators, such as the PESI or the simplified PESI, or the PE severity index. And in patients who have class 3 to 5 PESI or an S-PESI greater than or equal to 1, those patients are all necessarily going to be intermediate or high risk. And then in the intermediate risk cohort, we look at signs of RV dysfunction on either imaging or biomarkers. And the biomarkers that we're looking at are troponin and B-type natriuretic peptide. If both are positive, we then say that that patient is intermediate high risk. And if one or the other is positive, we say that that patient is intermediate low risk. If a patient is hemodynamically stable, S-PESI is 0 or PESI class 1 to 2, and they have no RV dysfunction, we say that that patient is low risk. And so what does this mean in terms of our treatment of patients? So this is a nice graphic of how we think about what to do with patients across the risk strata of pulmonary embolism. Second. So in the low risk patient population, we know that mortality rates are low, and therefore we give patients systemic anticoagulation, either with low molecular weight heparin, and then often transition to an oral anticoagulant such as a DOAC or warfarin. In the intermediate low risk patient population, this is the lower end of the intermediate risk population where mortality rates may be between 2 and 5%. And we feel that in most patients in this range, systemic anticoagulation alone should be sufficient. And the data has sort of borne out that that is the case. The patient population that we care about the most is the intermediate high and high risk patients, as there has been significant mortality across the years and not a lot that have moved in terms of those outcomes, and where a lot of the focus of some of the advanced therapies that we're going to talk about has moved to. And so in the intermediate high risk patient population, some patients have been studied looking at the use of systemic fibrinolytics, such as we use in high risk pulmonary embolism, systemic anticoagulation alone, and then there are some other not quite as invasive therapies that are catheter-based, including catheter-directed thrombolysis, a mechanical thrombectomy, and in some patients, surgical embolectomy, who are at highest risk of hemodynamic decompensation. In the high-risk patient population, those who present with pulmonary embolism and shock, these patients are given a class 1 recommendation for systemic fibrinolytics. So in the massive or high-risk pulmonary embolism population, what's the data that we have to support this systemic fibrinolytics? There's really only been one randomized trial that's been performed in this space comparing systemic fibrinolytics with heparin. This trial was stopped early after only 8 patients were enrolled because all 4 patients in the anticoagulation group died, and all 4 patients in the thrombolysis group survived to discharge. And this is really the only data that we have to support what we do in high-risk pulmonary embolism. So then we've asked over the years, what can we do in the intermediate risk patient population who have a significant increase in intermediate and long-term mortality as compared with the low-risk patient population? And so there have been several studies over the years looking at the use of thrombolysis in intermediate risk PE. And so we say, you know, if we've given systemic fibrinolytics to high-risk patients and they all survive, great. Can we do this in the intermediate risk patient population as well? And so there has been good data. This is a meta-analysis of the mortality in patients treated with thrombolysis in intermediate risk PE. There's a 52% relative risk reduction in mortality. However, this comes with the cost of a 3-fold increase in major bleeding in the thrombolytic arm. I'm going to focus briefly on the Pytho trial, which was conducted and published in 2014, which forms the foundation for a lot of the contemporary work that we've been doing in the pulmonary embolism space. So in the Pytho trial, this was a randomized trial of nearly 1,000 patients, a little over 1,000 patients, who were randomized in a 1-to-1 manner to either systemic fibrinolysis, albeit with a reduced dose of 50 milligrams, versus heparin for intermediate risk pulmonary embolism. The primary outcome was a composite endpoint of death from any cause and hemodynamic decompensation within 7 days from randomization. And we see here that this was quite a positive trial, with the tenecteplase arm significantly outperforming the placebo arm, driven predominantly by a decrease in hemodynamic decompensation. I highlight this down here as well to show that 4.6% of the patients in the placebo arm also received a thrombolytic treatment outside of the protocol. That being said, these were the concerning safety endpoints looking at major bleeding events. And so major extracranial bleeding, there were 32 in the tenecteplase arm compared with 6, highly significant. And more importantly, the rates of hemorrhagic stroke in the tenecteplase arm were 10 compared with 1 in the placebo arm. And so this caused fibrinolysis to really fall out of favor with the intermediate risk patient population. That being said, the investigators and subsequent trialists have taken from this that there may be a benefit to delivering some amount of fibrinolysis to patients with intermediate risk PE to improve their outcomes. So what's next? We have systemic lytics, which lead to less hemodynamic decompensation, but we have increase in major bleeding, including terrible rates of intracranial hemorrhage. So we ask ourselves, can we get the same effect of systemic lytics without the bleeding side effects? Are there other less invasive options to remove thrombus? Before 2010, our options for patients with PE, if you came in with shock and hypotension, you got lytics. Everyone else got systemic anticoagulation. We hope for the best. Today, we have a whole host of possible therapies that we can offer to patients across the spectrum of the pulmonary embolism presentation. We have catheter-based therapies, including catheter-directed thrombolysis, ultrasound-assisted catheter-directed thrombolysis, large and small bore catheter thrombectomy. In addition, we have ancillary support devices, including extracorporeal membrane oxygenation for patients who are in shock or incipient shock. We also have right ventricular assist devices, including the tandem heart and the Impella RP, which is designed specifically for the right side of the heart. We also have surgical thrombectomy and IVC filter placement in patients who can't tolerate any of the above. Zooming in on the catheter-based therapies, this is the summary of some of the currently approved devices for catheter-based management of pulmonary embolism. We have large bore thrombectomy devices, including the Inari FlowTriever, as well as the AngioVac and AlphaVac, which I have not included here. We have small to medium bore thrombectomy, including the Penumbra Lightning Flash, which comes in slightly smaller sizes and uses a slightly different technology, which we'll discuss compared with the Inari. And then we have catheter-based therapies, including the ECOS catheters, which in addition to having multiple side ports to deliver thrombolytics directly into the pulmonary circulation, also have an ultrasound core element, which is thought to open up some of the clots to enable deeper penetration of the fibrinolytic drugs. And finally, we have the Bashir endovascular catheter, which was recently FDA approved and is the combination of mechanical and pharmacologic thrombectomy. And so this nitinol cage here is expanded within the clot to open up the clot and then deliver TPA from the side ports that are built into the basket. And so what's the data for these therapies? Looking at ultrasound catheter-facilitated thrombolysis, the first trial that was published in 2014, shortly after the Pytho trial, was the Ultima trial. And this randomized about 30 patients in each arm to receive either ultrasound-assisted catheter-directed thrombolysis with heparin versus heparin alone. And the primary endpoints were the surrogate endpoint of RV to LV ratio, which we discussed earlier, the surrogate marker of RV-related mortality at 24 hours and 90 days. And we see here on the left that in the ECOS plus heparin arm, we had a significant reduction in the RV to LV ratio at both 24 hours and 90 days. In the heparin arm, there was no significant difference at 24 hours. However, at 90 days, the difference between the two groups sort of washed out. The second study that was fairly seminal in this space was the Seattle 2 trial, which was 150 patients in a single arm trial, again, looking at catheter-directed thrombolysis and the difference in RV to LV ratio at 48 hours. And they also looked at changes in the mean PA pressure in their follow-up as well. And we see a significant reduction again in the RV to LV ratio and a significant reduction both post-procedure and 48 hours later in the mean pulmonary artery pressure. So catheter-directed thrombolysis works. Can we make it even safer? These initial trials, I didn't include the data here, but still had modest rates of major bleeding. And so we want to know, we use 24 milligrams of TPA in the initial trials with these modest major bleeding rates. Can we get the same clinical benefit with lower TPA doses or shorter treatment times? And this spurned what's called the Optimize PE trial, which was published, I believe, in 2018, which looked at four different arms, about 100 patients, randomized to four different arms of different treatment lengths and TPA doses. The arm one was 4 milligrams per lung over 2 hours. Second arm was 4 milligrams per lung over 4 hours. Third was 6 milligrams per lung over 6 hours. And the fourth and final was 12 milligrams per lung over 6 hours. It's important to note that the fourth arm was terminated early in terms of enrollment due to an intracranial bleeding event, and that has fallen out of favor in terms of dose and timing of delivery. That being said, all four arms showed a significant reduction in the RV to LV ratio at 48 hours. And what we took away from this was that we can safely and effectively deliver lower doses of TPA and derive the same clinical benefit that we've seen in earlier trials with a much safer outcome profile. We then look to the mechanical thrombectomy literature. The first study in this space was the FLAIR study, which used the Inari FlowTriever catheter, which is a large bore mechanical thrombectomy catheter that's placed directly into the pulmonary arteries, and then using negative pressure that is created from a large syringe, performs aspiration thrombectomy. The initial design includes these nitinol discs, which were meant to capture some of the thrombus and facilitate thrombectomy, but ultimately fell out of favor as they were not felt to be particularly useful. Looking at these patients, we looked at, it was a multi-center single-arm study compared with the expected change in RV to LV ratio, which was derived from the Ultima trial. And it showed that there was a significant reduction at 48 hours of the RV to LV ratio. And they additionally looked at the PA pressures pre and post intervention and stratified this further by patients with elevated pulmonary pressures and those with normal pulmonary pressures at the time of procedure. And we see on the right here that those who had elevated pulmonary artery pressures had a significant reduction in mean PA pressure pre and post procedure, while those who had normal pressures did not have a significant change. So this was great data that ultimately led to the FDA approval for mechanical thrombectomy devices in the United States and updated the guidelines in the ESC 2019 guidelines. This was given a 2A recommendation for patients with intermediate and high-risk pulmonary embolism, stating that as an alternative to rescue thrombolytic therapy, surgical embolectomy or percutaneous catheter-directed treatment should be considered for patients with hemodynamic deterioration on anticoagulation treatment. So there have been many trials that have followed on this. Extract PE studied the penumbra system. Knockout PE was an extension of the Optimize trial with a prospective arm that excluded the patients who were in Optimize PE. This was performed at 64 sites internationally, 500 patients with intermediate, high, and high risk PE. And they all received catheter-directed thrombolysis. We see a reduction in the mean TPA dose to 18 milligrams. 31% received 12 milligrams or less. The procedures are quick, 40 minutes, 1% all-cause mortality at 30 days, 1.6% major bleeding rate, significant improvement from prior, and still a significant and sustained reduction in the RV to LV ratio, no intracerebral hemorrhages, and an improvement in quality of life. So what all of this data is missing, save for the Ultima trial and Pytho, is a real randomization. And so we're now in the era of learning what the real role for these advanced or catheter-based therapies are in the treatment of intermediate and high-risk PE patients. And the first randomized trial published in the space in the fall of 2024 was Peerless. And this was a trial looking at patients with intermediate risk PE and comparing large bore mechanical thrombectomy to catheter-directed thrombolysis. 550 patients were randomized in a one-to-one fashion to either CDT, which could be ultrasound facilitated or not, or large bore mechanical thrombectomy with the Inari FlowTriever system. Follow-up was at 24 hours, 7 days, and 30 days. The authors in this trial used a hierarchical composite endpoint that included, in order of hierarchy, all-cause mortality, intracranial hemorrhage, major bleeding according to the ISTH scale, clinical deterioration and or bailout, and ICU admission and length of stay. And this is, I don't want to get too into the weeds in terms of the statistics, but this is somewhat of a novel method of statistical analysis that's increasingly being used in device-based randomized trials. And it uses a statistical method called a win ratio, where all of these endpoints that make up the composite endpoint are compared between the arms in order of hierarchy. And when, one group or the other will either win, lose, or tie on each of these, and then it moves to the next in order of hierarchy. And it derives something called a win ratio to basically convey how frequently one arm versus the other won overall of the composite endpoints. So what are the results here? So Peerless was a positive trial for large bore mechanical thrombectomy. There was a statistically significant difference in the win ratio favoring large bore mechanical thrombectomy compared with catheter-directed thrombolysis. And so we see here with the primary endpoint, including all of the components of the hierarchical endpoint, there's a win ratio of 5.01, highly significant with a p-value of less than 0.01. That being said, one of the endpoints, as we see here, includes ICU admission and length of stay. And in patients who undergo catheter-directed thrombolysis at most centers in the United States, admission to the ICU for monitoring while they're receiving TPA infusion is mandatory as part of the post-procedural monitoring algorithm. And so, there's a lot of criticism of this trial stating that this is not really a reasonable endpoint to include in the hierarchical endpoint. And so if we look then at the secondary endpoint, which is a four-component win ratio, not including the ICU length of stay, there's no difference between the two. And so this doesn't mean that this is a negative trial, because the real endpoint here was, can we safely and effectively do this procedure? And what this showed us was that we can. There were very low rates of procedural complications. Mortality was less than 1%, and major bleeding was less than 1% as well. That being said, this has also spurned many further prospective randomized trials, which are currently enrolling. The HI-PEITHO trial, which is nearing the end of its trial, is conducted by the same group of investigators that performed the initial PEITHO trial. And this is going to be 406 subjects across 65 sites globally. And this is looking at ECOS versus anticoagulation arms. So this will be the first set of definitive randomized data looking at whether or not a catheter-based therapy offers any real clinical benefit compared to systemic anticoagulation alone. And this is using hard outcomes, including PE-related mortality, cardiorespiratory decompensation or collapse, non-fatal symptomatic, and objectively confirmed recurrence of PE. Peerless, we talked about PE tract is comparing any endovascular intervention with anticoagulation alone. This is a slightly different trial design, as it's really looking at more patient-centered outcomes in terms of their functional recovery, looking at peak VO2 at 90 days and their New York Heart Association classification at 1 year, and looking at major bleeding at 7 days. We have others, including Strike PE, Peerless 2, HI-PEITHO 3, which is looking at high-risk patients, and Persevere, which is looking at the FlowTriever versus standard of care for high-risk patients as well. And so what about this high-risk patient population? We've spent a lot of time now talking about the data that is going on in the intermediate risk range. And we look at the guidelines from the 2019 ESC guidelines of management of acute PE. And so in the high-risk patient population, we need to put patients on anticoagulation, class 1 recommendation for systemic thrombolytic therapy, surgical embolectomy recommended for patients with high-risk PE in whom thrombolysis is contraindicated or failed, and then 2A recommendation for percutaneous catheter-directed treatment should be considered with high-risk patients in whom thrombolysis is contraindicated or failed. So we have some guidance here, but we really need better data to understand what this is. And why not say, everyone who has high-risk pulmonary embolism should receive systemic lytics. Well, that's been a class one indication for many years. And at the end of the day, most patients who present with a high-risk pulmonary embolism will not receive systemic lytics. In many series, the rates are anywhere from 25 to 40%. And why is that? There's a lot of patients who have relative and absolute contraindications to lytics. There's also a increase in time to diagnosis that may prevent patients from receiving appropriate therapy, and it requires expertise. There are older series um, that are showing that these patients really don't get the care that they need. But in expert centers, we do have adjunctive therapies, and the paradigm may be shifting. So in surgical embolectomy, we think about high risk and some intermediate high risk patients who have contraindications or showing signs of hemodynamic collapse. Some patients with right atrial thrombus or paradoxical embolism may be appropriate for surgical embolectomy to prevent left-sided embolism um, of the PE or the clot in transit. And you need expert surgeons who know how to and can facilitate appropriate, timely care of getting the patient to the OR. Mortality rates remain quite high previously, although there's some contemporary literature showing dramatic improvements in expert centers in mortality rates. So what about ECMO? We mentioned this earlier as an adjunctive therapy. Most of you will know this, but ECMO is essentially, external cardiopulmonary bypass, most frequently placed in the periphery through the femoral arteries and veins. And the great advantage of using ECMO in patients who are intermediate high risk, who are decompensating, or high risk patients who already have shock or hemodynamic collapse is that you're able to provide full circulatory support and really unload the right ventricle and allow it to recover. In patients with contraindications to lytics, this gives time for anticoagulation to work or to decide on surgical versus percutaneous options to further debulk the thrombus burden. ECMO works. There's no randomized data as of yet, but there are many series, including in our own institution, that have shown dramatic improvement in patient outcomes. 30-day survival has improved from, roughly 17% up to 40% with the addition of ECMO plus or minus a adjunctive therapy, including intravenous thrombolysis, catheter-directed therapy, or surgical embolectomy. The FLAME trial was a prospective, multi-center, non-randomized observational study in high-risk PE. This was performed with the Inari FlowTriever, and patients were in one of three arms: the FlowTriever arm, the context arm, and prior therapy arms. So obviously, patients in the FlowTriever arm received mechanical thrombectomy with FlowTriever. The context arm is basically every other treatment as the primary treatment, and the prior therapy arm is lower risk PE treated with advanced therapy but progressed to high risk PE. And so we see the characterization of the patients here. Looking at the SCAI shock classification, there was a significant portion in the FlowTriever arm that were SCAI B and C, which are sort of the intermediate shock ranges, whereas in the context arm, there was a larger proportion of C, D, and E, so maybe a slightly sicker patient population. In the FlowTriever arm, I don't know why the number didn't come through, but the primary endpoint of all-cause mortality was 17% compared with 63.9 in the context arm. So moving past the acute PE and into the late-term complications of pulmonary embolism, as we said above and before, 4 to 10% of PE patients will go on to have chronic thromboembolic disease or chronic thromboembolic pulmonary hypertension. Patients with CTED may have exercise-induced PH, but will have normal resting pressures. CTEPH can be a severely life-limiting illness and will ultimately lead to progressive RV failure and death if left unaddressed. And so it's important to have longitudinal follow-up with patients after an acute pulmonary embolism to ensure that we identify these patients early and get them on medical therapy and consideration of either surgical or percutaneous management of their disease. And so CTEPH is a potentially tragic disease, but also is one of the only pulmonary hypertension groups that can be definitively treated. without transplantation. And so surgically, we can treat this with a pulmonary thromboendarterectomy, which is a timely and very invasive and long procedure, which involves essentially taking out the entire intima of the pulmonary vasculature, but does result in near universal cure of CTEPH. There are significant rates of recurrence of CTEPH in this patient population, but it is sort of the first line class 1 recommendation for these patients who are appropriate for treatment. There are medical therapies that we have available as well, with riociguat, which is the only current FDA-approved medication for CTEPH in the United States. This is a guanylate cyclase inhibitor. There are other targeted pH medications that can be used as adjuncts as well. And finally, there is, over the last 15 years, there's been development of a catheter-based procedure called balloon pulmonary angioplasty, which involves serial dilations of affected arterial branches to improve symptoms and PA pressures. There's no randomized head-to-head data comparing surgery with BPA, but the outcomes are quite good in patients who either have recurrence, distal disease, or are not surgical candidates. So how do we improve our care of these patients? There are many new treatments. It's very exciting, but we have unclear benefit yet in the long term beyond improvements in RV to LV ratio. Why have mortality rates remained so high over the years, and how do we streamline care to ensure timely, high-value care that affects patient outcomes? And why don't more patients who are eligible for advanced therapies receive them? Barriers to optimal PE care include too many stakeholders across multiple disciplines in the hospital. There's decision deferral and fatigue across providers. There's lack of expertise, both clinical and procedural. There's a wide range of presentations in various stages of care, and the key players are not in real-time communication to expedite care delivery. And this has fostered the development of what are called pulmonary embolism response teams, which began in the early 2010s with the goal of expediting care for patients with VTE, delivering timely and guideline-directed care for these patients, improve patient outcomes through rapid multidisciplinary decision-making for optimal PE management. These were modeled after the rapid response system that are fairly ubiquitous throughout hospital systems now that, bring a group of providers to the bedside of a patient who is at high risk for having an adverse outcome. And it brings all of the key stakeholders involved to offer the full spectrum of PE care. So this is a graphic to represent some of the components that are present at PERT teams across the United States and the world, which include pulmonary and critical care, cardiac surgery, cardiac and thoracic imaging, nursing, quality and safety, vascular surgery, interventional radiology, cardiology, interventional cardiology, hematology and oncology, and emergency medicine. And so does PERT help? Yes, the answer is unequivocally PERTs do help. So PERTs increase the access to advanced therapies. And so looking at a study that compared pre-PERT time with the contemporary PERT time at a single institution, we saw that there was no significant difference in the use of TPA in patients with PE. However, catheter-directed therapy, there was significantly increased access after the PERT era. No significant difference between surgical thrombectomy and a significant increase in any advanced treatment for PE. PERT saved lives. So this was published a few years ago, and it showed that in a pre-PERT and post-PERT examination of several institutes, the probability of death decreased significantly after the introduction of PERT, likely due to the fact that we have a multidisciplinary team intervening early in patients. PERT saves times. Our own institutional data has shown this. This is another study that has shown hospital length of stay is very significantly decreased with the use of PERT teams, again, due to the early application of guideline-directed therapies, enabling early transition to oral anticoagulants and discharge from the hospital with close patient follow-up. PERTs are recommended, after the initial experience and the initial data that has come out of the PERT centers across our country and across the world. It's now a Class 2A recommendation to set up a multidisciplinary team and program for the management of high and intermediate risk PE patients, which should be considered depending on the resources and expertise available. So, in conclusion, PE is a common and morbid condition affecting millions worldwide, with hundreds of thousands of PE related deaths annually. As we live longer with therapies to better treat conditions that predispose to VTE, the incidence of PE continues to grow. And after decades of being caught between the hemodynamic decompensation seen with anticoagulation alone and the bleeding risks inherent in systemic lytics, we're at a critical juncture in the field where we have safe and effective catheter-based therapies and a growing body of high quality literature to support and further elucidate which patients are best served by additional therapies. We do need further prospective randomized trials to further delineate and define the optimal treatment of intermediate risk and high risk PE. Thank you all for your time. I'm happy to take any questions. And this is my email in case anyone would like to reach out.
Thank you very much, Dr. Robert, for that excellent presentation. We will now open the floor for questions. Please feel free to raise your hand or submit your questions via the chat. I have one. Could you share, Dr. Robert, your experience with pulmonary artery thrombectomy in patients with CTEPH at your center? What patients profiles do you typically consider for this approach, and approximately how many cases or procedures you perform annually?
Yeah, it's an excellent question. And I want to clarify one point. So when you're asking about CTEPH patients for thrombectomy, are you talking about surgical PTE, or are you talking about balloon pulmonary angioplasty, or are you talking about patients with acute on chronic clot who have underlying pulmonary hypertension? Jorge, can you hear me?
Yeah, yeah. I
Yeah.
have a lag in the audio.
No problem. Yeah, I'll answer the question as I think it's intended. And so, in speaking about patients who have chronic thromboembolic pulmonary hypertension, the catheter-based therapies are ineffective for chronic clot because they become marginalized and endothelialized to the walls and essentially become part of the arterial vasculature, which is why it's necessary to perform a pulmonary thromboendarterectomy. Um, this procedure started at the University of California, San Diego, many years ago now. And for a long period of time, it was a very niche group of surgeons who were doing this. But as the years have gone on, many have gone on to be appropriately trained in this. And so there are pulmonary hypertension centers across the United States who have well-trained surgeons. But it also involves having very highly knowledgeable pulmonary hypertension specialists, either cardiology or pulmonology or otherwise, who are engaging in the medical management of these patients and the long-term follow-up. Um, we are very fortunate to have both excellent medical pulmonary hypertension specialists and a very talented surgeon who does our PTEs. And I would say that we do on the order of about 50 PTEs per year. San Diego is still sort of the hub of this, and they probably do 200 or 300 a year. But you know, this is a highly specialized surgery. To give you all context, in order to do this surgery, you know, normally when you go on cardiopulmonary bypass, you're cooled down to 32 degrees Celsius. When they do a PTE, they need to do this in a bloodless field. And so they cool the patient down to 19 degrees Celsius and do what's called a circulatory arrest, which they do for, you know, many of the aortic procedures as well. And during that time, you essentially have, you know, no perfusion to many of the organs of the body. And so you have a very limited time frame to work in order to prevent ischemia, particularly to the brain. And so after this is done, you usually have about 35, 40 minutes per side to perform the entire thrombectomy. In between, you restore perfusion and rewarm the patient for a period of time and then have to cool them again and do the other side. So it's not something that the average cardiac surgeon is going to be doing, but in specialized centers, the outcomes are incredibly good. And so it's important to have centers of excellence for pulmonary hypertension management where you have the appropriate medical and surgical expertise in order to take care of these patients. Many patients will benefit from having a lead-in period with medical management, including riociguat and other pulmonary hypertension targeted therapies prior to having their surgery to decrease their pulmonary artery pressures to the highest extent possible to make the surgery that much safer. Um, and so that is hopefully answers your question in terms of the volume that we see. We have, because of our expertise in the pulmonary space as well, from our interventional cardiology group, myself included, we do a fair amount of balloon pulmonary angioplasty as well for either non-surgical candidates, patients with mild distal disease, or patients who have recurrent pulmonary hypertension. There are very high volume centers in the United States that do hundreds of these a year. We probably do on the order of, 40 to 50.
Thank you, Dr. Robert. We have a few questions in the chat, including some from our cardiology residents at the university
Mhm.
training program. The first one is from Dr. Roberto. Uh, Thank you for your excellent presentation. I'm interested in your thoughts on the use of RB, LB radio as the primary endpoint rather than mortality or other hard clinical outcomes. In your view, is this endpoint sufficient to justify regulatory approval by the FDA?
Excellent. Yeah. And I see the rest of the question by Roberto as well. These are fantastic questions, Dr. Calvo. Um, I agree with you, and I think the vast majority of appropriately skeptical cardiologists and otherwise in the United States would say maybe, maybe not. As I said earlier in the talk, there is good data to show that RV to LV ratio greater than zero point 0.9 is a good surrogate marker for mortality in patients with acute pulmonary embolism. That being said, it does not replace the hard endpoint of mortality itself, because as we know, with retrospective data, there is a lot of confounding that can really affect, associations between two things. And so I will say that um, if we care up front about showing that the patient's RVs will improve both in size and function earlier than with systemic anticoagulation alone, because as we saw in Ultima at 90 days, there was really no difference. Um, that's a good clinical endpoint if we can do it safely. Okay. Um, but I think we all agree that we need prospective randomized data with hard endpoints to really define whether or not these therapies are moving the needle. I think the reason that these endpoints are used, which is not a great excuse for it, is that when you look at something like the intermediate risk patient population, clinical trials are invariably flawed in some way in that they're often cherry picked in whom they include, and oftentimes the sickest patients in a set of clinical patients are not included in that trial. And so when you have sort of an intermediate risk population on the lower end of the risk spectrum, and you really need to get the event rates to see whether or not there's a statistical difference, using surrogate endpoints may get you to that faster than looking for mortality rates, which may only be, 5% in one arm and 7% in another. We've seen in these trials that the early term mortality rates are extraordinarily low, which is great. But again, if you're looking at the lower end of the risk spectrum, that probably doesn't tell the whole story. And so that's, a plug that I'll make for the high Pytho trial that is probably going to be presented this fall at one of the major conferences, that is looking at catheter-directed thrombolysis versus systemic anticoagulation, using hard endpoints of death and hemodynamic deterioration. It is not using any surrogate endpoints. And so I very much look forward to that. As to whether or not this justifies regulatory approval. Um, that's a it's kind of a longer question, and there are certain pathways in the United States and Europe um, that allow devices to make it to market with surrogate endpoint data, which I think is kind of a larger ethical discussion, but it is sort of the nature of things. And thankfully, the data has now borne out that these procedures are incredibly safe. We've also, I didn't include this, for the sake of time, but we've also, found over the years that we are further risk stratifying these patients based on the data that we often get in the cath lab. And so there's a cohort of the intermediate risk population that we get into the cath lab whose blood pressure is normal, heart rate's mildly elevated, hypoxic, looks good on paper. But then you do a right heart cath and you find that their cardiac index is 1.6, and they're actually in shock sitting in front of you, despite the fact that their end organs are, mostly perfused and their blood pressures are adequate. And so we're learning more and more about this patient population as well, and whether they derive further benefit compared to those who are not in shock. And I think there's still a lot of work to be done. But you're absolutely right. Large randomized data needs to be obtained and published to really guide what the appropriate use of these devices is. Um, and as to the second part of your question regarding aspiration thrombectomy, um, I I don't think it will become the first line treatment for pulmonary embolism. But I think if the data shows that it is superior to systemic anticoagulation, it should become in those institutions where the resources are available to provide hemodynamic support if necessary, should become the first line therapy for high risk pulmonary embolism because as we discussed, somewhere between 20 and 30% of patients who should get systemic lytics are getting them. And B, those patients who receive them, there's, a 6 to 10% major bleeding rate. Whereas if you take a patient to the cath lab with or without hemodynamic support and you're able to successfully debulk the thrombus burden, you may have significantly better outcomes, but I think we may need further data to support that. And again, if you've read Peerless or seen any of the press on it, it's being touted by the people who ran it as a wildly positive, mechanical thrombectomy superior to catheter-directed thrombolysis. I don't think that really holds up in terms of, looking at the hard endpoints that were part of the hierarchical composite endpoint.
Thanks, Dr. Robert. The Dr. Emilio have a questions. Dr. Emilio, you can turn on the microphone and ask Dr. Robert.
Do you hear me?
Yes, I can.
Dr. Zilinyi, I want to congratulate you for your excellent lecture. And I would like to ask, in what cases are you still using systemic thrombolysis in patients of intermediate high risk? Especially taking into account that we do know that evidence is every time bigger related to catheter-directed thrombolysis, but in some resource-limited scenarios, like in our country, we do not have wide availability of these kinds of therapy. So in your center, for example, in what cases are you still using systemic thrombolysis in intermediate high-risk patients?
It's a fantastic question. And a couple of components to my answer. I would say that it is exceedingly rare. The dose for someone who has a high risk pulmonary embolism is 100 milligrams of tenecteplase or alteplase given over 2 hours. Okay, unless the patient is actively suffering a cardiac arrest. Um, in Pytho, they used 50 milligrams of tenecteplase. So it was already a reduced dose. There was a subsequent study called the Moppet study, which also looked at 50 milligrams dose of TPA. And it wasn't quite as compelling as Pytho, but it showed slightly safer bleeding profile compared to Pytho for unclear reasons. Um, and so I would say that we very rarely use it in the intermediate risk population or in the intermediate high risk population. Because at the end of the day, the bleeding risks, inherent in using systemic lytics of just about any dose. And as we saw in Optilice, even giving patients 2 milligrams an hour for 6 hours resulted in an intracranial hemorrhage. Really probably don't outweigh the benefits that you might derive from giving it in this patient population. There are some series that um, have shown mortality rates up into the 20s in this, intermediate high risk population. But I think that, if you really had true epidemiologic data on all of this, you would find that it's probably in the 5 to 7% range. And when your risk of intracranial hemorrhage is, 6 to 8%, and your mortality risk is 5 to 8, it's a hard risk benefit ratio to stare down. We are very fortunate to have the resources that we do, but I'll say that when we were in the midst of the COVID pandemic, we could not do any catheter-based therapies for these patients. And so, we were operating in, really, a real-time simulation of what really not having these resources at our disposal were. And there were many thromboembolic events that we saw with COVID, still unclear whether or not they were causal or just sort of coincidental. But we actually saw a fair amount of clot in transit in patients who would otherwise be, classified as intermediate risk pulmonary embolism. And we gave a couple of patients sort of mop-it dose TPA. And some of them did fine, and one of them died of an intracranial hemorrhage. And so I would exercise extreme caution in these patients. In patients who have high risk PE, class 1 indication, your mortality risk is as high as 60%. And so I think the risk benefit is definitely in the favor of systemic lytics if you don't have access to adjunctive and more advanced therapies. That being said, if you are in a place where you don't have, catheter-based therapies, but you do have cardiac surgery that can provide ECMO support, there are some patients who have, contraindications to lytics in whom you can put them on VA ECMO and allow them to rest on anticoagulation, offloading the RV, which is really the cause of death in these patients, and allow the anticoagulation to do its work. But these are very complicated circumstances and really depend on the resources of the area and the hospital that you're in.
Thanks.
Dr. Robert, I think we can do the last questions. Dr. Leah have two questions. The first one is what to do if we have a CT scan that confirms right chambers compromise. If you do perform a transthoracic echocardiography in the immediate period, or it doesn't change your decision of therapy in these patients. And the second one is, what do you think? What is like the use of the IBC filter as an option? Your thoughts about it?
Excellent questions, and thank you for them. So, either CT or TTE can tell you that a patient has RV dysfunction or dilation. You don't really need both. I will say that the standard from the research side of things is to have an RV to LV ratio to understand, the extent of dilation, et cetera, on a CT pulmonary angiogram. And we as a center who are enrolling for major clinical trials and have very robust internal database on all of our PE patients, still fight to get our radiologists to report an RV to LV ratio. And instead, sometimes they say, there's straightening of the interventricular septum, suggestive of right heart strain. And then people call us panicking in a patient whose heart rate is 60 and they're on no oxygen and they have negative biomarkers. So it's incumbent on you as the doctor to look at your primary data and look at the RV and say, does this look like it's as big or bigger than the LV? That's helpful. You're also most of you are cardiologists and have the skill set to take an echo probe and put it on the patient. If there's uncertainty on the CT, you can absolutely go and check for yourself. You don't need a formal echo. You can just go look and see if the chambers look enlarged, hypokinetic, if you see a McConnell's, et cetera. Um, and make a determination for yourself. You are ultimately, if you're going to be involved in the care of PE patients and decision making regarding what therapies they should receive, you ultimately should be the arbiter of whether or not there is right ventricular dysfunction by either biomarker or imaging. If there's clear RV dysfunction on the CT, you don't need a formal echo. It's helpful to get one if you have the time, but if you have a patient who looks like they're not doing that well and you have RV dysfunction on the CT, or even if you don't and you have elevated biomarkers because the CT didn't pick it up, make the decision that's in the best interest of the patient. It doesn't mean that intermediate low risk patients shouldn't ever get catheter directed therapies. But the vast majority of patients who will probably benefit from it are going to be in that intermediate high. I hope that sort of answers that question. And I'll segue into your second question. I include IVC filters because they are technically part of the algorithm in terms of managing VTE. That being said, I'm not a fan of them. I try to use them as sparingly as possible. People do not realize that, in the acute period, when you have a patient who has a contraindication to systemic anticoagulation and has a lower extremity DVT, you may benefit them from preventing embolization of that DVT. That being said, you're putting a foreign body into someone's intravascular space, and that is thrombogenic in and of itself. And if you put it in, leave it alone, and don't start anticoagulation when you need to, it's going to propagate thrombus itself. And so we try to minimize the use of them to as few patients as possible. There are some patients who have common iliac DVT, occlusive common iliac DVTs that may benefit. That's probably the only space that we have data that shows that those patients benefit in terms of preventing further embolic events, even if they're on anticoagulation. But I would say that, my general approach to these patients is if they can tolerate anticoagulation, I don't put an IVC filter in them.
Thanks, Dr. Robert. As we conclude this excellent session, I want to extend our deepest gratitude to Dr. Robert for sharing his profound knowledge on this important subject. I don't know if you would like to give some last word.
I think that my final words and thoughts on this is that you are all going to be the front line of taking care of these patients in many of the institutions that you will go on to practice at. And it's not just the acute period that matters for these patients. Yes, it's nice if we can do something in the acute phase to help them improve their outcomes in the long term. But these patients are at high risk for recurrent VTE events. They're at high risk for post-thrombotic syndrome, for CTED, for CTEPH. Even if the incidence is small, like as I said, there's millions of people each year across the world who are diagnosed with pulmonary embolism. It's the third most common cardiovascular problem in the world. These patients need your help. They need to have prompt identification of persistent symptoms, progressive symptoms that may belie an underlying pulmonary hypertension that requires either medical or surgical management, and prompt referral to an expert center in those cases. And I think if we are diligent, I think if you take whatever resources you have available to you wherever you go, and you are interested in this field and you want to make a difference for your patients, work to develop a system where you have something like a PERT. PERT is worldwide now. There are PERT centers and PERT teams all across the world, and they really do affect patient outcomes, and they allow for prompt and timely management. And this is not the motivation, but they save time and money to healthcare systems that are already strained from time, space, and financial standpoints. And thank
Professor,
you all for having me.
Professor, on behalf of the cardiology program at the University of Antioquia, thank you once again for your time and dedication. Wishing
My
you
pleasure.
all the best in your future. Goodbye and stay well.
Thank you very much, Jorge. And thank you, everyone. Gracias a todos.